Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. We are the last group that will be presenting. We are group 6 and we will be present chapter 9, which is leading person-centered practice. And next I will move on to the chapter objective. The first one is identify the policy and professional drivers for the development of patient-focused services. Services such as healthcare services, mostly lah. Choices of maybe medicine or choices of consultation, and the promotion of consumerism with health and social care. The next, examine the power base that underpin the practitioner-patient relationship. Underpin mean to support the the power base that support the practitioner and patient relationship. And the third one is define person-centered care and identify prerequisites and barrier. Prerequisites mean to prior condition to the application of this concept to practice. Next, explore the concept of patient involvement, participation and partnership, and their application within the context of your professional practice. This I will explain in the next few slides. And lastly, reflect on your leadership strategies for enhancing person-centered care within your practice setting. Okay, sir. Okay, for the background of leading person-centered practice started in England. Patient choice and empowerment are currently central themes in national policy in England. They all started the concept of individualized patient-centered care started in 1991. And the name is Patient Chartered. Patient Chartered promoted the concept of individualized patient-centered care and also the sign of beginning of providing patient with right regarding the regarding the healthcare services that they receive. So there are 7 key areas of public and patient right. The first one is access to health service. All patients must have right to access to any health services at any time. Next is quality of care and environment. So patients should receive a good quality of care and a good environment while receiving the access to health service. The third one is nationally approved treatment, drug and program. Respect, consent and confidentially informed choices. So the patient have the right to be informed all the choices that they have, so they can make. Next is involvement in healthcare and the NHS. NHS is National Health Services. So the patient have right to involve when they have access to health, so they have right to involve. And lastly, the patient have right to complain and redress when they receive the treatment, and they have right to complain about what they are unsatisfied. Okay, for next, there are mechanisms that support the patient and public involvement within the National Health Services in England. And the first one is patient advice and liaison service. It was aimed to ensure that NHS listen to patient, whatever their voice be voiced out, and answer their question and resolve the concern. They must do that. So they must ensure that the NHS listen and answer the question and resolve their concern. And then also they provide source of feedback to respective provider of healthcare. Next is Health Watch England. This has a national role for people who use health and social care service to ensure that their voice are heard by the Secretary of State for Health, the CQC, NHCE, NHSI and all local authorities in England. The third mechanism is Health and Wellbeing Board. They bring together local commissioner of health and social care, elected representative and representative of local health watch to agree an integrated way of improving local health and well-being. And lastly, local health watch. Local health watch comprise independent local organisation with role to provide citizens and communities with a voice to influence. They provide the voice for them to influence, challenge how health and social care services are provided within their locality. So, patient advice and liaison services PAS, they are ensure that NHS listen to their voice. So local health watch, they are provide the citizen and community with a voice to influence. They provide the way to voice out. Like that. Okay, we move on to patient and survey users of partnership, participation and involvement. So hierarchical relationship exists between the three concepts of involvement, participation and partnership. Okay, patient involvement or collaboration is a prerequisite or a prior condition for patient participation, which in turn is a prerequisite for patent or a great partnership. Okay, patient involvement means they are more than simply engaging people. Okay, involvement is having the patient voice heard at every level of the service, even when the voice is whisper. Okay, evidence show that the patient safety improve when patients are more involved in their care and have more control. Okay, we move on to patient involvement. Okay, patient involvement require more passive in nature. Patient will be more passive because the health or social care practitioner provide the information or elicit information from the patient as part of the assessment process. So just when we go to clinic, we as a patient will involve, but the social practitioner or healthcare practitioner will ask how you doing, what you have been through, what are you sick of. Okay, so we being asked or being evaluated, we as a patient. Next, we go to participation. This when it was necessity more active involvement from the patient. Patient required to being more active, such as when practitioner engage the patient is an evaluation of his or her care. So we as a patient, after the being evaluated or being asked by the healthcare practitioner, so we as a patient, we give them the information, we participate, such as I've been going through headache for a few weeks, I've been hurt this and that for a few days. So we must participate. If the patient does not give any cooperation, then the participation was not there. And lastly, for partnership, equality within patient and practitioner relationship. It's to contracting with the patient through goal setting or development of a care, therapy or birth plan. For example, when I go to clinic, I tell the doctor that I want to reduce my weight. So the doctor give their solution, and we both have the same goal. For me to achieve that goal, and for the doctor to set the standard of goal. So we are going to the same way, going to the targeting the same goal. So that is for partnership. So there are attributes of patient participation. There was being identified that a number of defining attribute. So without the attribute, the concept might not have been surfaced or achieved. So the attribute are the presence of relationship between healthcare and practitioner patient, such as partnership that I explained just now. Narrow relevant info, knowledge and competence gap between healthcare practitioner and patient. Surrendering of a degree of power controlled by healthcare practitioner. So mostly we patient, we go to healthcare service to have their consultation. So we must hear their voice. They have control over us, for us to getting better. Okay, and engage in selective intellectual physical activities during healthcare process phase, such as physiotherapy. When I go, me myself, I have injured my ACL, so I go to physiotherapy, do the physical activities such as squat, one single leg squat and like that. So I must engage in selective intellectual or physical activities for them to access, for me to attribute to the patient participation. Lastly, positive benefit is associated with the intellectual and physical activities. So here the second last of my explanation, which is potential or sources of power of healthcare practitioner. Power can form a significant role in healthcare practitioner and patient relationship. The first power of healthcare practitioner is their knowledge of expertise, their education and their experience. So this determine how fast they can get the solution, or how expert they are in their field of medication. And the language they being used is medical terminology. And the environment, delivering of care therapy within the environment of a healthcare organization. So the environment, of course, they have the environment of a healthcare organization they are comfortable with. For uniform, they represent status. Uniform also may get to play a main role. When we see the nurse uniform, we know that they are nurses. So when we get to the treatment room, we see different type of uniform. We know that it was a doctor. So we have a confidence that we're being consulted by a Okay, sir. Okay, lastly, professional autonomy, gatekeeper to treatment, care and therapy. So the professional autonomy, such as doctor, the therapist, the specialist, like that. So these are the power of the healthcare practitioner. And lastly, the potential source of power of patient. Okay, so patient usually have the knowledge and expertise on they get the information from internet. So maybe before they get consultation from the doctor, maybe they search their illness through the internet. So they ask what I've been going through, like that. So impact of their illness on everyday experience. So the knowledge impact their illness. So the more they have the knowledge, maybe they will get to prevent earlier illness. So environment, care, therapy, treatment delivered within patient home. So patient have the power to get the treatment, do the treatment by themselves based on their knowledge that they get at their own home. And they also have right to complain, have right to ask for second opinion, have right to refuse treatment when they go to when they are accessing the healthcare services. So that's all from me. I will pass this to Hanna.
I'm Hanna. We continue this presentation. Next is leading person-centered practice. The terms of person-centered practice are also known as individualized care, consistently feature within government documents regarding the modernization of both health and social care services. Health Foundation states that the person-centered care involves putting patients and their family at the heart of all decisions, where patients are regarded as equal partners in planning, developing, assessing care to make sure it is the most appropriate for their needs. So, these are the key concepts for person-centered in healthcare, which are heart choice. HEARTC. H is for holism, E is empowerment, A is advocacy, R is respect, T is trust, and lastly, C is for choice. Now let's see what is holism. Holism concludes for the whole person, both physically and also psychologically. Within a holistic approach, physical, social, psychological, spiritual, and also cultural issues are recognized as having collective impact on the well-being of the individual. Second is empowerment is to provide power or authority to another person. Third is advocacy, which is someone who acts on behalf of another person. The advocate needs to understand the values, beliefs, and also perspective of the person whom they are representing. For example, those relating to their role of professionals versus their role as an employee of the healthcare organization. It must also be acknowledged that within the practitioner-patient relationship, the level of advocacy required will vary from patient to patient and will be dependent upon a number of factors such as mental capacity and the preference of the individual patient. R is for respect, which to have positive regard for another person. Mutual respect and positive regard should ideally be evident in both sides of the practitioner-patient relationship. Trust relates to the reliability of another person and having confidence in them. Within practitioner-patient relationship, the patient must be assured that the practitioner will address their best interests. Last but not least is choice. Choice is having the opportunity to select a preference from range of alternatives. The hard choice model can be used to inform and lead the achievement of true patient-centered within everyday practice and can be applied at all levels within the organization. Next is strategies for promoting person-centered. There are actually 4 strategies which are prerequisites that focus on the attribute of the nurse. Second is the care environment, which focus on the context in which care delivered. Third is person-centered process that focus on delivering care through a range of activities. Lastly is expected outcomes, focus on which are the results of effective person-centered nursing. McCormack conclude that in order to deliver person-centered outcomes, account must be taken of the prerequisites and the care environment that are necessary for providing effective care through the care process.
My name is Nurin Nazirah. Next, I would like to continue about practice that support person-centered working. There have 4 types in this slide. For the first one is about a ticket to go home. The first step is patients are provided with an individual whiteboard in their room that details information regarding what they need to achieve prior to being discharged. Second, provides a practical tool that acts as a mechanism for 3-way communication and engagement between the patient, family, career, and healthcare practitioners. To maintain confidentially, a person's health record may be more appropriate than an individual whiteboard. The next slide is about the patient diary. They have 3 explanations of patient diary. The first one is the use of patient diary presents the healthcare practitioner with an opportunity to learn from the everyday experience of the individual patient and to use this information in meeting, their personal care, therapy, or care. Next, use in palliative care where the patient uses a diary to record symptoms, emotions, and problems. The diary can be used to identify problems, needs, and the impact on individual to monitor care and to solve likely subsequent problems. The next slide is about practice that support person-centered working of summary care record, or well known as SCR. The first process in SCR is electronic record implemented by NHS or National Health Service. Next, contains information about medications, allergies, and reactions to medications as appropriate. The third one is the record can be accessed by healthcare staff. Following confirmation of permission from patient, can liaise with their GP to add other information to their SCR, and they also have choice out of the SCR. The last slide that I would like to talk is about personal health budgets, or well known as PHP. The first point is allocation of funding given to patients after an assessment, which can be taken as a direct payment. Next, PHP also provides an amount of money to support a person's identified health and well-being needs. planned and agreed between the person and their local NHS team. My last point in this slide is PHB provides individuals with more choice and control over how their needs and meet. That's all from me. Thank you.
Hello, I'm Idiel. For my slide, I will talk about achieving patient-centered. Achieving patient-centered care patients with diverse needs. Within health and social care, there are a number of patients who may need more specialist consideration and support in identifying and meeting their personal values, beliefs, and needs. It may include those who are unconscious, cognitive impairment, or other mental health problems, communication deficit, or learning disability. Next, I will talk about biographical approaches. Biographical approach can support the achievement of a person-centered assessment for patients who may have a cognitive impairment or learning disability. Second, individual patients are afforded the opportunity to share their life experiences to provide insight into their values, needs, and aspirations. The use of biographical approach can promote patient-centered care through the personhood of the older person. Last but not least, I will talk about Advanced Directive AD. AD is also known as Living Will. The use of AD is enable a competent individual to outline the treatment and care that they would like to receive in the future, should they subsequently lose the capacity to decide or to communicate their preference. AD or Advanced Directive also refer to advanced decision and consists of endowing durable power of attorney to a surrogate decision maker.
Hi, I am Alissa Qian. Now I would like to present about the challenges to the achievement of person-centered care. The achievement of person-centered care can pose challenges for the healthcare practitioner, which can be personal challenges, cultural challenges, or even resource challenges. The challenges to the person or individual can include their personal values, attitude, and belief, and the influence that this may have on their care delivery, such as in the situation where the practitioner is a non-smoker and the patient who is pregnant or has chronic obstructive pulmonary disease choose to keep smoking. The next one is challenges relating to the culture of the care environment. It can include routine working practices, such as expectation by the day staff that the night staff will complete a number of bed baths before the shift handover. So lastly, the challenges relating to the availability of resources can include environmental factors, such as having a limited number of side room or shower, or maybe relate to consumable resources like the type of toiletries and hospital clothing available to the patient. Next is the factor as having the negative impact on an individual's sense of self and their personhood. So we have here is stereotyping, labeling, depersonalization, stigmatization, ageist attitude and belief, changes in health status, lack of real choice and autonomy, physical environment, rigid organizational boundaries or service access criteria, task orientation based on routine and tradition, and lastly is the lack of knowledge, skills, and insight by the caregivers. Now we move to the relationship between the healthcare practitioner and the patient. The healthcare practitioner-patient relationship is central to health and social care practice. The interpersonal relationship between the healthcare practitioner and patient humanize care and therapy through identifying with the patient personal experience. So now we talk about identifying a patient willingness to participate in this. The choices are divided into those that are governed nationally, those who are available locally, and other preferred choices that they would like to be widely available. So for the choices governed nationally, we have general practitioner, care provider, and concern or refuse treatment. For local choice availability, this can be the time for the therapy or the menu. And lastly is the other preferred choice that includes individual room, timing of consultation, or maybe unrestricted visiting.
Assalamualaikum, my name is Mikael. I'm the last presenter. Next, we will go through to the last topic of the chapter, which is compliance versus non-compliance. First, labeling patients using terminology such as non-compliant can be perceived as paternalistic. What is the achievement of patient compliance with treatment, therapy and advice can sometimes be challenging for health and social care. Second, NICE 2009 differentiate between intentional and non-intentional non-adherence with medication and has produced a clinical guideline aimed at addressing this. The clinical guideline made recommendation regarding how healthcare professionals can be help patients to make informed decision by facilitating patient involvement in the decision to prescribe together with how they can support patient to adherence to the medication. There are 4 approaches recommended by NICE, which is a frank and open approach, which recognize that non-adherence is the very common. Second, a non-blame approach, encouraging a patient to discuss non-adherence and any concern they have about their treatment. Third, a patient-centered approach that encourage and inform adherence. And lastly is identification of specific individual, perpetual and practical barriers to adherence. Third, concordance related to medicine taking is more contemporary approach to prescribing that involvement share decision making between the patient and health care professional. With concordance bring the outcome of the process, this approach recognize the belief and preference of the patient and acknowledge that to achieve compliance, patient need to know how medication will benefit them personally. It is an example of the promotion of partnership between the patient and the healthcare professional. And lastly, we will go through to the implementing similar approach within other areas of healthcare patient. It's important to analyze the factor that influence individual patient decision to comply or not with the treatment, therapy and advice. That is all for me. Next, we go through to the next subtopic. Thank you. So next we go through to the good practice guideline for ensuring person-centered care. So firstly is talk and listen to patient. Ask them about their experience and evaluation of care and take positive action to address any concern. So with this, we'll be able to identify which part of the service or facility in the hospital that need to be improved in order to satisfy the patient while they in the hospital. Second is involve patient in all decision about their care and promote informed decision making and choice. So for example of this point is give an advice to them in medical term or to help them feel ease and more informed about the medical. And third, which is establish the patient preferred form of address and ensure that this documented and respected by team member. And lastly is prepare plan of care in collaboration with patient and ensure that they are reflective and individual value, belief, concern and personal preference. So that's all for me for the last topic of this chapter. Thank you for hearing. Bye.